My name is Dr. Stephen Paget. I'm the chairman of the Division of Rheumatology at Hospital for Special Surgery. And it's a pleasure today to introduce Dr. Terry Edersheim, who is a clinical associate professor of obstetrics and gynecology at the Weill Medical College of Cornell University. She is a superb obstetrician and gynecologist and has a particular interest in high-risk pregnancies, and I think most specifically in the area of lupus. So we'll talk to her about those issues today. Dr. Edersheim, pregnancy is an interesting state. Why can it be so affected by diseases such as the ones we take care of here?
Well, the diseases that we take care of here are often manifest in blood vessels, and pregnancy should be thought of as an experiment in blood vessels. That's what placentas are. And any condition that affects blood vessels will affect the pregnancy, and vice versa. The pregnancy will affect the patient with the underlying vessel disease.
I think that's a wonderful concept. You are, at least one hat that you wear, is a high-risk pregnancy gynecologist and obstetrician. What does that mean, and who should be coming to see you?
Well, the Board of Maternal and Fetal Medicine was started to take care of patients who had medical diseases in pregnancy and who had obstetrical issues in pregnancy. So primarily we take care of things like lupus, diabetes, hypertension, renal disease in pregnancy, as well as multiples in pregnancy, triplets, twins, people with incompetent cervix. That's who should be coming to see us. But often people who just have advanced maternal age because of in vitro fertilization and assisted reproduction. We're seeing many women having babies after the age of 40. And that's another group who comes to see us.
Some of those disorders that you just mentioned support that concept that you mentioned, in that they involve vascular type problems. If we can move to systemic lupus erythematosus, which occurs predominantly in young women who clearly desire, many of them, to become pregnant, what do you recommend as the best time for the rheumatologist to become involved in communicating with you?
Well, we communicate throughout the pregnancy and hopefully before the pregnancy with the rheumatologist. My idea of the perfect lupus pregnancy would be the one in which I see the patient before they get pregnant. I see them as they're beginning the whole process, in other words, so that I have a chance to speak with the rheumatologist from the beginning, and we can discuss the medications the patient's on, the ideal time for the patient to get pregnant, and that we consult with the patient continually during the pregnancy and after, because those are all important times for lupus in pregnancy.
It must be a complicated issue because, on the one hand, obviously the couple desires to have a child. On the other hand, there's a possibility that that pregnancy may have a negative effect either on the mother or the child. How do you address the issues of making the appropriate decision?
Well, we divide the issues into two parts. One is, how will the pregnancy affect the fetus? And the other one is, how will the fetus affect the mother? Anyway, so that we start with, will the mother get worse? Will lupus be deteriorating as a result of the pregnancy? And in order to decide that, we have to know from the beginning what condition the mother's in, obviously. So that with the rheumatologist, we start by knowing the patient's renal function, the patient's blood pressure, the medications the patient is requiring at the time, what is the history of the disease in the patient, is the patient at a quiet time or is this an active time for the lupus in the patient, can the patient be on different medications or no medications. For the fetus, it's a question of monitoring the fetus throughout the pregnancy, because there are many things which can impact on the fetus that are important. And as long as we keep in mind that there are two patients here and evaluate both patients continually, we usually do fairly well.
Are there absolute indications to avoid becoming pregnant when you have lupus?
Absolute indications.
Or is it usually almost negotiated and discussed with regard to almost a cost-benefit decision?
That's the issue. There are optimal situations in which somebody should get pregnant. The optimal situations are when the disease is most quiet, particularly if they have renal complications. We would like to see patients get pregnant when their renal manifestations are at its most quiet point and when they're requiring the least amount of medication possible. That doesn't mean that the disease won't get worse during pregnancy. Often just the stress of pregnancy will make the disease worse. But we have the best chance of not having lupus flares during pregnancy if their disease is quiet. In patients who are on the verge of needing dialysis, patients who are on the verge of being transplanted, those are the times which we would not want patients to get pregnant. Those are the times in which the disease is likely to push them over the edge, and those are the times in which the manifestations for the fetus would be worst, particularly prematurity and intrauterine growth restriction.
And what do you do in a situation if you give a couple a 20% likelihood of a good and safe outcome for the mother and the child, and yet they still want to go ahead, or they come to you pregnant? What do you bring to bear from an academic medical center to help them get through that?
Well, you and I have been in that situation together many times. We would focus on taking care of the mother and taking care of the fetus. Pregnancy isn't something that always is planned. And when it isn't planned, what we can do is monitor the pregnancy closely by monitoring the mother closely and the fetus closely. How do we do that? With the rheumatologist, we would make sure that we evaluate the peripheral manifestations of lupus, the renal disease in the patient. We would make sure that we check for antiphospholipid antibody syndrome, which is a very important part of the effect of lupus on the pregnancy. In terms of the fetus, in the third trimester, we would use antepartum testing evaluations and ultrasound evaluations to look for fetal growth and placental function. Those are the things that we do in our tertiary care setting. We also have an excellent neonatal intensive care unit, which is often called upon in these situations.
With regard to controlling the disease, are there medications that we as rheumatologists use outside of pregnancies that can actually be continued during pregnancy and that they can be safely taken by the mother?
Absolutely, there are. The one that we use most often is prednisone. Prednisone crosses only in minuscule amounts, crosses the placenta in minuscule amounts, so that it very rarely gets through to the fetus in any amount which would be significant. Where it does get through to the fetus, in fact, we use steroids often to help mature the baby's lungs. So this is not a drug that we worry about in pregnancy. With any medication in pregnancy, we deal with what is the condition of the mother, how does the mother's condition impact on the pregnancy, and how would medication improve the mother, and is this medication therefore worthwhile? There are medications which we don't use. For instance, we don't use methotrexate in pregnancy. We don't use cyclophosphamide in pregnancy. But we use the antimalarials in pregnancy, and there is little, if any, effect of that medication, so chloroquine is fine. So it's a question